Good afternoon, everybody. Thank you for joining us for another edition of SPA Live. Sorry for the technical difficulties and the delay in getting started, but thank you for joining us this afternoon. Today we are talking to Nathan Favero, an associate professor in our Department of Public Administration and Policy, who is in Denmark this year studying doing his research at Aarhus University. And it's a little cooler and a little later in Denmark, but we appreciate Nathan joining us today to talk a little bit about research that he's doing around COVID-19 testing in the United States. It is a little bit outside of what Nathan traditionally researches, but I'd like for him to give us a little bit of an insight into what compelled him to do this research and what he's finding so far.
Well, thank you, Che, and thanks to those of you tuning in. I'm delighted to be able to share a little bit about my research. As Che mentioned, I've not been researching COVID-19 for very long. I guess nobody has, but I'm trained as a political scientist. And so when the coronavirus outbreaks first started, like everyone else, my life was hugely disrupted. And I felt this. I found myself online a lot, clicking refresh and trying to figure out what was going on, reading lots of different articles, like many of you, I'm sure. And at first, I thought, okay, as a social scientist, the main thing that I can do is to try to do some survey research and learn a little bit about people's attitudes and what makes them willing to social distance or not. And I did a research project or two based on that. But over time, as I started reading more of this information, I realized that I thought I could do a bit to try to create some information about how to basically combine two different measures of how bad COVID is or the outbreak is in a particular area. So the two measures that a lot of public health folks are looking at and citing that I try to combine into a single measure are the number of cases that have been confirmed in a particular area, maybe within the last day, within the last week, and the percentage of tests that are coming back positive, tests for COVID in that particular area. And a lot of public health officials point to these two measures. The second one, the percent positive, gives us some indication of whether or not we're doing enough testing, to what extent we might be undercounting COVID-19 with our case numbers. And so that's why those two measures are important to use together, because we know that there's a problem with undercounting. Not everyone gets tested who has COVID-19. And so what I did is I tried to create a method to combine those two into a single measure that would give us some sort of an idea of, are things getting better? Are they getting worse? While taking into account that maybe our testing volume has changed, in particular in the United States. We've seen testing volume kind of consistently increase over the last several months. And so once we take that into account, what kind of picture do we get? And that's what the paper that I've written and the website that I have is focused on, is giving us a way to answer those kinds of questions. And then on my website, actually producing graphs to show at a state level as well as nationally, what does the picture look like once you take into account an adjustment for the case numbers that accounts for how much testing you're doing.
And that website is covidtrendlines.com, correct?
Yeah, that's right. COVIDtrendlines.com. I'm not doing a very good job selling my website, am I?
For our listeners out there, it's an easy one to remember, and we'll put it in the comments section of the Facebook Live broadcast if you're interested in looking at it. COVIDtrendlines.com, where you have a blog and you have graphs and you're showing a lot of the research methodology that you've put together there, so it'll answer a lot of questions. But that reminds me that if you're watching on Facebook, please leave your questions in the comment section. We will talk to them, speak to your specific questions over the course of this meeting. That's why we're here, to take questions from the audience. But before we get into that, some of the things that people have been talking about lately is the different kinds of tests that there are out there. I mean, I think most of us are familiar with the pretty invasive nasal swab test that is sort of the gold standard, but we've run into problems with supplies and getting accurate test results back quickly, which has hindered sort of, I think, the public health response. What other sorts of ways of testing are there, and how can that help us more accurately track the spread?
Yeah. Well, to simplify a little bit, there's basically two categories of tests that are at least being widely used and reported on. So one is viral tests, and those include that sort of nasal swab. Sometimes they just swab the back of your throat. When I came to Denmark, they're testing foreigners, and so I actually got a COVID test, but they just swabbed the back of my throat, not my nose. And then sometimes there's some saliva-based tests that have at least been tested. I'm not sure if those are being widely used, but all of those are viral tests. And basically what they're doing is they're trying to see, do you currently have the virus in you? Now there's some potential that the virus may be dead and not active sometimes when you're doing these tests, so it doesn't necessarily perfectly indicate that you're currently infectious, but it's doing something that at least approximates that. The question is, do you have the disease right now, is basically what it's trying to test, even though it can be a little bit imperfect, because sometimes it could show up just because you had the test. Maybe you had the disease last week, but you may no longer be infectious. So that's the first category of tests, is these viral tests. The second category that gets talked about a lot is antibody, sometimes also called serology tests. And these are trying to see, do you have in your bloodstream perhaps any of these antibodies that your body generally produces in reaction to a disease that you encounter. And so this is not trying to test if you're currently sick. It's trying to test, do you have antibodies that your body would have produced if you were sick in the past? And so these two types of tests are fundamentally trying to measure different things. The viral test is, are you trying to measure basically, are you sick right now? Whereas the antibody test is saying, are you sick? Were you sick in the past, and would you maybe have some immunity currently to COVID-19? Now, one distinction that I think is helpful to think about, especially when we're thinking about how do you use these kinds of tests, is something that I came across from a researcher named Carl Bergstrom. I believe Joel Miller is another researcher who also made this point. Both of these people on Twitter, I follow them. That's how I come across their stuff. But basically, there's three different uses that we can think of for these tests. So one of them is personal health. If my doctor's trying to figure out how to treat me, they want to know what I'm sick with. And so that's the first use, and you're going to want a viral test for that kind of thing. And you need it to be really, really reliable, right? You want to know, do I have the disease or do I not? And so even if something is really uncomfortable, like the nasal swab, and maybe it takes a day or two to get results, we want that high reliability. A second use for tests is what's called surveillance in public health, which is basically just trying to get a sense of how much disease is there in a community. And that's the kind of thing that we need to know in order to make policy decisions, right? Do we need to shut bars back down, right? Is something that's being discussed in some communities. Do we have any sense of whether or not masks are working to control the disease, right? So that's surveillance. You're not trying to figure out if an individual is sick necessarily. You care more about what does the community look like? How prevalent is the disease currently or maybe in the past? And both types of tests, either the antibody or the viral test, could be useful for that purpose. And then a third thing that gets talked about is what Carl Bergstrom calls mitigation, which is basically the idea, I want to know if I'm sick so that I know whether or not I might be passing that on to anyone else or have passed it on to someone in the past, right? So it's not about my doctor trying to tailor their care to me based on whether or not I have COVID or not. It's thinking about, what can I do to make sure I'm not spreading this to others, or maybe to go follow up with other people I have had contact with and let them know that they may have been exposed to COVID. So that would be a third category of why you need testing, is for mitigation purposes. So anyways, those are just a couple ideas to help think about. There's a whole lot more that could be said about tests, but some of the different kinds of tests and the different uses of tests.
Mm-hmm. Is there other sources of data that government can be using besides like results and case numbers that we're seeing?
Yeah. So I think probably the two most common sources of data or numbers that we see popping up are the number of confirmed cases, which is what we've been talking about, which is developed through testing, and then COVID deaths. We've all seen those numbers and those charts being shared as well. And COVID deaths, sometimes those are confirmed through viral testing, right? And in general, we worry a little bit less about underreporting on deaths. We probably undercount deaths somewhat, but people who get sick enough to actually die from COVID are much more likely to actually get access to that test and have their case investigated than somebody who's just sitting at home and maybe has some symptoms or maybe doesn't,
Hmm.
but doesn't go into the hospital because it's never that severe. So we worry a lot more about that undercounting when it comes to that number of confirmed cases than we do when it comes to deaths. Although there's certainly still underreporting problems with deaths, and especially early on before we had much testing available at all, where maybe even people in a hospital, people who were dying, weren't getting tested. But especially these days, we don't worry quite as much maybe about the underreporting. The downside with the death data is that it gives us more of a view of how many people were infected maybe a month ago than it does currently, because people who die from COVID generally don't die as soon as they get the disease. It often takes several weeks, maybe a month, for somebody who has a fatal case of COVID to actually die from the disease. And so because of that, deaths are more of a lagging indicator of how severe things are. Now, it's also important to say that the number of confirmed cases is also a lagging indicator because most people don't even have symptoms and wouldn't think to get tested until maybe 5 days, a week after they initially caught the infection. And so our testing data doesn't tell us what the severity is or the prevalence currently. It probably tells us what it was like a couple weeks ago, depending on how quickly tests are being processed and the data being reported. But deaths are going to generally lag even further behind the case count. One other source of data that many of you may have heard about is hospitalization numbers. And that's also a good source of data. It doesn't lag as far behind as deaths. So in that case, that way it's a little bit more helpful. One downside with the hospitalization data is that there's really a lot of inconsistency across states and localities in terms of how that's being reported. Some of that I think has improved a little bit over time. But depending on what data source you're looking at, you may or may not be able to get good hospitalization data that covers the whole country. So that's, I think, one of the main reasons that there's been more reliance on the case counts and the death counts than on hospitalizations is just because there's been less standardization in terms of how hospitalizations are being reported and whether they're being reported at the state level at all.
So it sounds like standardization is in one way that governments could do a better job, but what are some of the other ways that they could do a better job reporting the sort of results they're seeing?
Yeah, yeah. So there's a lot of things that they can do, and I think the two basic things we could come up with lots of different subcategories within each of these. But first of all, to have common standards that are being used throughout the U.S. and ultimately throughout the world, if you want to be able to make comparisons across countries. I've been focused on U.S. data, but to have common standards of how things are being reported across states, across counties, and things like that. And that's where I would argue the federal government has a really important role to play, right? We want our local and state governments to be very involved in COVID response, and there's a lot of things that they have to take the lead on because of the way that our government is structured. But we really do need common standards to be set by the federal government so that we have comparability across different localities in the U.S. And I think the second thing, in addition to sort of these common standards, would be to have just consistently reporting and good detail in what's being reported. So, for example, I would love to do the sort of analysis that I've been doing at the county level, but we don't really have data available at the county level with the amount of detail that I need to be able to run my analysis. In particular, there is sometimes case data or death data that's being reported at the county level, but there's not any consistent source of data on the total number of tests that are being conducted at the county level. That's only available at the state level, and I need that in order to be able to create my estimates. And so because of that, we're limited. Some states are publishing this information at the county level, but other states aren't. And so consistent and detailed reporting of data is really important, as well as that consistency in terms of how different states are doing it across the United States. Those would be two things that would really help us to have a better handle on things. There's also been some recent sort of disruptions where the Health and Human Services Department at the federal level changed the way that hospitals were supposed to be reporting some information to them, and that's led to some disruptions. Now, there's always a trade-off with making these kinds of corrections to data protocols, because in theory, this may give us a better system where hospitals aren't having to report to multiple entities and they can just send out one set of reports and really spend their time focusing on patients rather than reporting compliance. But I think that there's a lot of concerns about how the transition was done, as well as whether or not once hospitals are reporting this information to the federal government, to Health and Human Services, whether or not states then get access to that data, right? I said earlier that states and local governments are really important players. A lot of the public health responsibilities fall on them to respond to this pandemic. And so if the federal government isn't quickly and efficiently and completely sharing that information that they're getting from hospitals back down with the states and the localities, then you have a problem, right? So it's not that it should fall on the hospitals to send out the same report to every entity, but we do need to make sure that that data is somehow getting to all of the relevant parties and the relevant stakeholders. And I'm not sure that's being currently done based on some reports I'm seeing from some different folks.
We do have a question from the audience, and again, I want to remind folks to leave their questions in the comments. But are they doing? We're talking a lot about numbers, right? In certain states, the infections are at X number. There's 10,000 a day or whatever, but we're not really looking at rates, right? The rate of infection in a certain state, or the rate. I mean, we're not talking about it as much. Is there a reason why that's the case, or is it because we're not standardizing across different states? Do you have any theories on that?
Yeah. No, that's a good question. So on my website, one of the things I haven't mentioned, but if you go to my methodology section, you'll see is that I am actually reporting this as a rate. So basically, I'm making an adjustment where I'm reporting cases per 100,000 people, and then making a slight adjustment upwards where maybe one case counts as 1.2 cases if there's not a lot of reporting. Now, that's not going to give you an accurate view of exactly how many people have the disease, because even if you have a really high level of testing, you're probably going to miss a bunch of people who are asymptomatic, who would never think to submit for a test or something like that. But my point is that all of the estimates that I'm showing are saying, in relative terms, how many confirmed cases are we getting per 100,000 people in the state? And so that's something that some folks are doing. I'm certainly not the only one doing this in the way that I report things. You can find lots of other sources that will report things, usually in terms of per 100,000 people. I think World in Data is an international data source. They have it on lots of different countries, and you can sort of click lots of different boxes to select how the data is being displayed. And they give you the option to either show the raw number or the number of cases or death or whatever you may be looking at per 100,000 people. And so I think it does get reported both ways, but some sources only focus on one or the other. And I think, on the one hand, the raw numbers are maybe more intuitive, right? It's easier to convey and understand what the y-axis says if you're just talking about the raw numbers, which is probably why that gets focused on a lot of times. But if you're trying to actually make comparisons across two different locations, it's really important to have it in relative numbers. And so what I'm trying to facilitate with my estimation approach and on my website is comparisons across jurisdictions or within the same jurisdiction over time. And for those purposes, well, over time, it doesn't matter so much because the population isn't changing a lot over time, and I don't have a measure of how the population is changing over time. But when you're comparing across states, it's really important to have that rate, just as is being highlighted in this question.
And that, I think, leads to another question, which is, as we have the sort of different standardizations like you talked about, what are some examples of where COVID data is being used badly?
Yeah. So I guess I've thought about kind of three buckets of ways that maybe data is getting used badly. So one of them is not accounting for lags. As I mentioned earlier, it's not like someone gets tested and their case gets reported as soon as they get an infection, right? It takes some time between getting infected and for that case to potentially show up in a report that a state or a county or the federal government is putting out. And then, like I said, deaths tend to lag even further behind. And so not accounting for those lags and the different nature of lags, depending on which measures you're using, is one problem. And we saw examples of this when people were saying, well, cases have been going up, but we haven't seen any increase in deaths, right? And I think a lot of us who have spent a lot of time with the data said, well, it's probably, unfortunately, only a matter of time before we see deaths rise too. But deaths take longer to show up in the data than confirmed cases. So that's why we saw a big period of increase in cases in the US before we saw an uptick in deaths. So that would be one example, is failing to account for the lags. A second thing is when you fail to account for reporting delays, which is sort of related, but it's more specific to the type of data. So it's not saying how long does it take for someone to show symptoms or how long does it take for someone to show up in the hospital or to potentially die after they get exposed to the disease. Instead, I'm thinking about how long does it take for the data to get processed? And we see this especially in death data, where there's actually different sources of death data that are sometimes getting reported. So if you look at the US CDC, Center for Disease Control, you see that they have two different sources of deaths that get reported depending on which part of the website you're on. And in one case, those are deaths that are being reported sort of as soon as they get confirmed. And in another area, they have data that's actually relying on death certificates that get sent to the CDC and then get processed. And that data takes a long time to get processed. And so if you look at any graph that's using that death certificate based data, you're going to see that deaths are really low in recent weeks. That's because those weeks haven't been filled in yet. So I've seen people point to those graphs and say, we've seen a huge drop in deaths, when really that just means we haven't filled in the death data for those recent weeks yet. So that would be another example. And then a third example of problems that I see, and this is not an exhaustive list, of course, there's other problems with data, but is when people don't acknowledge that maybe the missingness in the data. And specifically, I'm thinking about, I've seen several graphs looking at hospitalizations over time. And a lot of those graphs are pretty misleading because, as I mentioned earlier, there's not consistency in how hospitalizations are being reported. And specifically, if we look back in, I believe it was mid-March, there was really only one state that was reporting hospitalizations consistently, and that was the state of New York. In recent weeks, we've seen that, at least if you're using COVID tracking as your data source, that almost all states are now reporting hospitalizations, although there's been a little bit of disruption because of that switch in how hospitals are reporting data that I mentioned earlier. So if you look at this series over time in terms of how many hospitalizations have been reported, the beginning of the series is only going to be showing you hospitalizations from New York City. And gradually, more and more states start reporting their data, and this data becomes less a description of New York City or New York and more a description of the whole country. So folks who aren't accounting for that and just plotting the data without realizing these are national figures that are aggregating different numbers of states over time, you get a very misleading graph. So that'd be another example of how it comes down to people downloading the data without taking the time to really understand it before they create a graph that they maybe upload onto Twitter or something like that.
Mm-hmm. Which probably leads to like a lot of misinformation and chatter and misconception about what's going on to the general public. With that in mind, this is a question from our audience. Are there valid sort of case fatality rates that are being followed or that we can follow? Or is there anybody out there or any organization out there putting out numbers that seem relatively reliable?
Yeah. I think there are actually lots of people doing very responsible research, and then there's lots of folks who aren't, right? And probably have no ill intentions, but maybe are a little bit over their head in terms of what they're trying to take on. And the trouble as a consumer of information, right, is trying to figure out who's reliable and who's not. So I guess, one thing I did before this chat was jot down a few resources that I thought might be helpful. And, now might be a good time to share a few of those. So one of them would be just the CDC website. There's a ton of different sections of the CDC website that have a ton of different information. There's also a couple of journals that the CDC publishes that have lots of topics that they cover, but in recent months, it's been disproportionately COVID-19 studies that are getting published there. So go look those up, and you're going to find answers to a lot of questions, including things like case fatality rates. And if you dig far enough on the CDC website, you'll see that they have estimates of, they used to report what's called a case fatality rate. Now they're reporting an infection fatality rate, and those are slightly different numbers for reasons that I won't go into right now. But you'll see those kinds of estimates being put out and discussed by the CDC. And there's been a lot of criticism of the CDC, and they certainly haven't done a perfect job in especially, I think, navigating some of the political pressure that's been put on them by the current administration. To try to make things look rosier than maybe they are or look a certain way. And so occasionally, some of the information that I've seen from the CDC, I've seen a little bit of criticism of, but I think that that's the exception rather than the rule. Most of what's on that website is very much in line with what public health experts are saying, and occasionally when they maybe feel some political pressure to do something like say we really need to open schools, right? You might see that in the top line that they're really pushing opening schools. But if you actually read down further into their recommendations, they're giving pretty detailed and I think what most people consider good advice about what are the things the schools need to do in order to be able to have a safer environment and stuff like that. So I think it's still a very good and reliable resource overall, even though there's been some questions about politicization of some of their information. So that's where I would point you to if you want information about like an infection fatality rate is the CDC, although there's plenty of other sources as well. A couple other resources I'll mention really quickly. I already alluded to COVID tracking. This is covidtracking.com is a website that has been created by some folks. The Atlantic magazine is running this. It's called the COVID Tracking Project. They've been assembling data from all the different states as they report it for months now. Basically, they said, we wish CDC was doing this, and if CDC had a good repository, and hopefully they will someday, we'll go into, we won't be needed anymore, so we'll shut down the website, but they're kind of filling in as a stopgap until CDC is able to do that. And I think part of this comes back to CDC not having enough resources, right, to be able to fill all of the many, many, many needs that they were thrust upon them in the midst of a crisis. But they've done a great job, and they also have a blog where they have some really useful posts where they discuss some of the differences in data, how are states actually counting and confirming that a death is due to COVID-19 as opposed to a death that's unrelated, and some of that kind of stuff. So really, really good information coming out of covidtracking.com or the COVID Tracking Project. So I highly recommend them as a source of information. And then a third one, I just tweeted about this. So if you go and find my Twitter, you'll see my most recent tweet is a list that an epidemiologist named Ellie Murray, created on Twitter. And it's just a list of COVID experts on Twitter. And so that's one of the main sources that I use when I'm trying to go get information, is this list of, I think it's 79 people or something like that, who are active on Twitter and do research on medical topics of various kinds, and are now doing research on COVID-19 and are good scientifically reliable sources of COVID-19 information. So I tweeted that list out just before this so that it would be easy for you to go find if you wanted to find that list. But that's been a huge resource, and there's a really good epidemiology community on Twitter that has been putting out really good information. So.
We do have one more question from the audience before we kind of close out our discussion this afternoon, but you talked a little bit about school reopening and things like that, and the need for really good data as we move forward into the fall. I mean, as you see in the United States, a lot of school districts are now deciding to move online in the absence, I think, of really crystal clear data. Is there value in reporting sort of the prevalence of antibodies in a community? If we start expanding the kinds of tests that we do to pool testing and antibody testing, is there value in that?
Yeah. I mean, more testing is definitely going to help, and multiple kinds of testing. Um, I think, the antibody tests can be helpful in maybe giving us some sort of an approximation of how many people might have immunity to COVID-19 in a community. And that's helpful information to have, even though it's a little bit tentative because there's still a lot we don't understand about immunity to this disease yet. Um, but as more people become immune, the chains of transition get weaker. And so there's probably more you can get away with in terms of opening if you have some immunity within your community than if you don't have any. So antibody testing could be useful. This pooled testing, which allows you to really ramp up the volume of number of people that can get tested, would be really helpful. There's some discussion about having some viral tests. So these are not looking for antibodies, these are looking for active infection, but maybe they're less reliable, right? But they're really cheap and maybe not invasive. You don't have to do that nasty nose swab to be able to get results, and maybe you get results quickly. That kind of thing could be useful as sort of an approximation to figure out what's going on in your community. They're not reliable enough for your doctor to be prescribing you things based on them, but maybe they can give you some sort of an idea of whether or not you have a problem in your community. I think there's lots of room for all kinds of things like this to help us out in our reopening, and thinking about school decisions and stuff like that. There's also a friend was telling me that here in Denmark, they've been doing random viral testing. So they go and get a random sample of the population and ask them to take these viral tests. And that gives you some sort of an idea of, now we're not waiting to see if people have symptoms and then testing them. We're just getting a random sample of the population. So that's going to give us a much better idea of what proportion of the population is currently infected. So I think, all of these techniques can be helpful, and more data is going to help. The biggest concern that I have about reopening schools in the US, and of course every community has a little bit different situation, but just thinking about the US as a whole, is that testing helps you, but only to a point. And I worry that in a lot of communities in the U.S., the rate of disease, the number of people who are infected is just so high that it's hard to think about a way that schools could currently be reopened safely, I think. We have a lot of countries around the world that have reopened schools, and it seems to have gone pretty well, but most of them have very few infections compared to how many the US appears to have right now. And so, I think all that testing data is going to be really helpful and help policymakers and schools to make good decisions and identify people who are sick and isolate them and that sort of thing. But if you just have a huge number of infections, then that data isn't necessarily going to help you a whole lot because there's too many people who are sick to really have schools open in a safe way at all, is what I'm worried about. And so I think that the first step is to get the number of infections down. The second step is to bring in a bunch of that data that you're asking about. And I think that's the how we should be thinking about reopening things, including schools, is that first we have to get infections down, and then testing and PPE and all these other strategies are really going to help us to be able to keep it low and not have a big flare up.
And last question then, as someone who's researched for a while now and has dealt with a lot of data and seen how people report data, do you see the trend getting better? Are we getting more of a handle on how to report this data, or are we still going to be muddling through the fall? I mean, it's understandable in March when the pandemic hit that not everything was in place, but now as we're in July and August and going into the fall, are we trending upwards in terms of accurate data?
Yeah. I think that the data situation has been improving, and in particular, we have a lot more testing than we did, even a month ago, but especially 2 or 3 or 4 months ago. And so I think the fact that we have a lot more testing improves what we know a lot. And that's just, I mean, it's been a very steady increase in the number of tests that we've been conducting in the US. So I think it's improved in that way. I think the hospitalization data has been improving, even though there's been this recent disruption with the difference in how it's being reported. So I think that the reporting and detection of deaths is getting better. So I guess the short answer is yes. I think that the data is getting better across the board. it's hard to project the course of the disease, and in terms of, is the prevalence going to increase or decrease moving forward? And that's something I don't feel qualified at all to really model or project.
Hmm.
I tried to stay very, very narrow in what I'm doing in terms of my estimation, which was just to take these two measures that all the public health experts are pointing to, and then combine them into a single estimate. And that's pretty much all I feel that I can contribute with my statistical training, but without having a lot of knowledge of how to model the way that this disease might change over time, or the way that it might change in its spread over time. And so, I think one other thing I would say is that, if states look different, different states look different, but if we look at things at the national level, what you maybe see in my estimates that correct for the reporting volume that looks a little bit different than if you just look at the raw number of cases being reported, is that throughout a lot of April and May, we really did see a decrease in the number of infections, I think. And you see that in the death data too. But if you just look at the raw number of reported cases, you sort of see a plateau throughout most of April and May. And I think that the reason that looks like a plateau instead of a slight decrease is because we were expanding our testing volume throughout that time. So we were catching more cases, but we weren't necessarily seeing a true plateau. I think it was a little bit of a dip. And to me, that gives me a little bit of, you know, reason for a little bit of optimism. I don't think that the situation in the U.S. looks good right now, but we figured out how to decrease cases before, just like
Hmm.
much of the world has. And so I think that, we did see a real decrease in the prevalence of the disease. We saw deaths drop, and then we saw a big ramp up. And in the last, week or so, we've seen some evidence that it looks like we finally hit a plateau again. And I'm hopeful that will turn into an actual drop in the number of cases and in the incidence of the disease. Deaths are going to lag a little bit behind, so we'll probably continue to see an increase in those for another couple of weeks. But yeah, I don't know what course the disease is going to take, like I said, but that's sort of what I've seen, is that we did have a period where it was decreasing nationally, and now we seem to have finally hit a plateau instead of continuing this increase that we've seen for several weeks.
Okay, well, thank you, Nathan, for your insight today. Well, I think we're going to leave the discussion here, but I want to leave people with some resources. Again, the site that Nathan has set up is covidtrendlines.com, where, Nathan, you're posting your research. There's a blog. The methodology is there. Please take a look and get familiar with it. As the fall goes on, I'm sure you're going to be posting there again. Also, I'll say that you can follow Nathan on Twitter at Favero_Nate. So please follow him. I'm sure he's going to be tweeting out a lot of interesting resources and research as the fall goes on. Also, you can follow us at _AU_SPA. We'll be linking to all kinds of stuff that our faculty is doing this fall. Nate, enjoy your time in Denmark. Thank you again for joining us today. And hopefully we'll have a chance to talk again later this fall, maybe with some good news in store.
Great. Yeah, thank you, Che.
All right. Goodbye.